The single most effective thing you can do for your blood pressure isn't cardio. It isn't cutting salt. It isn't even losing weight. According to research published in the British Journal of Sports Medicine, one of the most surprising findings was a 2-minute wall sit. Sounds ridiculous, but after digging through the research on every major blood pressure intervention, I found that some of the things everyone talks about barely work, while a few, almost nobody talks about work surprisingly well. So in this video, I'll cover all of them, and I'll start with the most surprising one. Let's go. Disclaimer: I'm not a doctor. I'm someone who got obsessed with health research and runs experiments on himself. Before you apply anything from this video, check with your own doctor first. The 2023 meta-analysis I mentioned at the top was published in the British Journal of Sports Medicine, and it pooled 270 trials covering nearly 16,000 participants. The researchers compared every major exercise modality head-to-head for blood pressure effect. The ranking surprised even the authors. Isometric exercise came in first, with an average systolic drop of 8.24 millimeters of mercury and a diastolic drop of about 4 millimeters of mercury. Combined aerobic plus resistance training came in second. Aerobic cardio and dynamic resistance training were essentially tied for third, both dropping systolic pressure by around 4.5 millimeters of mercury. That's a much flatter picture than the old cardio is king assumption most people carry around. So what counts as isometric exercise? It's any contraction where the muscle generates force without changing length. The classic example is a wall sit, where you slide down a wall until your thighs are parallel to the floor and just hold the position. Another example is an isometric hand grip, where you squeeze a device at about 30% of your maximum strength for 2 minutes at a time. The protocol used in most of the trials is almost embarrassingly short. You do 4 holds of 2 minutes each, with a 2-minute rest between holds. You do that 3 times a week. Total time on task is around 8 minutes per session, or roughly 24 minutes per week. That's the whole protocol that produced the biggest effect size in the meta-analysis. The mechanism is interesting. When you hold a sustained contraction, the working muscle clamps down on its own blood vessels and restricts flow for the duration of the hold. When you release, blood rushes back through, and the vessel lining gets a strong signal to release nitric oxide. Nitric oxide is the molecule that tells your arteries to relax and widen. Repeated exposure to that signal seems to recalibrate vascular tone over a period of weeks. The catch is that isometric holds are genuinely uncomfortable. A 2-minute wall sit at proper depth is much harder than it sounds. You should also check with your doctor before starting if you have any existing cardiovascular condition, because the sustained contraction does spike pressure during the hold itself. But for evidence quality, effect size, and time efficiency, nothing else in the literature comes close. Aerobic cardio tied with resistance training for third place in that meta-analysis, but it's still the most heavily studied intervention overall, with enormous trial volume behind it. The pooled effect is around 4.5 millimeters of mercury systolic and 2.5 millimeters of mercury diastolic. The current guideline target is 150 minutes of moderate intensity aerobic activity per week. Moderate intensity in practical terms means you can hold a conversation but not sing. That's Zone 2 territory. Zone 2 has become a buzzword thanks to Peter Attia and Inigo San Milan, but the underlying point is real. At that intensity, your body is primarily burning fat. Your mitochondria are getting a strong training signal, and your cardiovascular system is adapting without a lot of stress hormone release. 2 practical takeaways here. First, the dose response is real, but it flattens. The jump from 0 to 150 minutes per week gives you almost all of the blood pressure benefit. Going from 150 to 300 minutes adds a little more, but the curve flattens fast. So if you're starting from sedentary, you don't need to become a marathoner. You need to become someone who walks briskly for 30 minutes 5 times a week. Second, the combination of aerobic plus resistance training came in second in that meta-analysis, ahead of either one alone. So if you have the bandwidth, 2 cardio sessions plus 2 strength sessions per week is the better evidence template than pure cardio. Let's talk about DASH diet. Across the full study population, the DASH eating pattern dropped systolic pressure by about 5.5 millimeters of mercury and diastolic pressure by about 3 millimeters of mercury over an 8-week intervention. In participants who already had hypertension, the effect was roughly double, closer to an 11-point drop in systolic pressure. The pattern is straightforward. You're eating roughly 4 to 5 servings of vegetables per day, 4 to 5 servings of fruit, 2 to 3 servings of low-fat dairy, 6 to 8 servings of whole grains, and you're keeping red meat to a few times per week. Legumes, nuts, and seeds round it out. It's basically a Mediterranean diet with a bit more dairy. The reason this pattern works mechanistically is because it delivers high doses of 3 minerals that directly regulate vascular tone. Potassium relaxes blood vessels and signals the kidneys to dump excess sodium. Magnesium boosts nitric oxide production. Calcium plays a role in smooth muscle regulation, and the fiber load shifts the gut microbiome towards species that produce short-chain fatty acids, which also lower blood pressure independently. Honest caveat, DASH is hard to comply with long-term in real life. The trials that show the big effects fed people prepared meals. The follow-up data shows that real-world adherence drops sharply after a few months, and so does the blood pressure benefit. The takeaway isn't to fail at strict DASH for 6 weeks and quit. It's to permanently shift the ratio of plants, legumes, and whole grains to processed food in your weekly intake. If you can't overhaul your whole diet, 2 specific food categories punch above their weight on blood pressure, and the trial evidence is solid for both. First, potassium. A 2017 meta-analysis in the International Journal of Cardiology found that increasing potassium intake to around 3,500 to 4,700 milligrams per day dropped systolic pressure by an average of about 4 millimeters of mercury in hypertensive participants. The richest food sources are potatoes, sweet potatoes, beans, lentils, spinach, avocados, and yes, bananas, although bananas are actually not the highest source per serving. A medium baked potato has roughly twice the potassium of a banana. One important note: potassium supplements are not the same thing as potassium-rich foods, and high-dose potassium supplementation can be dangerous if you have any kidney issue. So this one is genuinely a food-first intervention. Talk to your doctor before touching a potassium pill. Second, dietary nitrates. This is the beet juice research, and the data is surprisingly strong. A 2013 meta-analysis in the Journal of Nutrition pooled 16 trials and found that beetroot juice supplementation dropped systolic pressure by about 4.4 millimeters of mercury on average. Worth flagging, most of these trials were short, ranging from a couple of hours up to about 2 weeks. So how well that effect holds up with long-term daily use is less certain than the single number suggests. The mechanism is direct. Dietary nitrates from beets, arugula, spinach, and other leafy greens get converted by bacteria in your mouth into nitrite, then into nitric oxide in your bloodstream. That nitric oxide tells your arteries to relax. The practical dose in the trials was around 250 to 500 milliliters of beetroot juice per day, or the equivalent in nitrate-rich leafy greens. A large salad with arugula and spinach gets you into the right ballpark. One quirky detail: using antibacterial mouthwash blunts the effect because you need the oral bacteria to do the nitrate to nitrite conversion. Magnesium is the one supplement in this stack with strong randomized trial data behind it. A 2016 meta-analysis in hypertension pooled 34 trials and found that magnesium supplementation at a median dose of 368 milligrams per day for an average of 3 months dropped systolic pressure by about 2 millimeters of mercury and diastolic pressure by about 1.8 millimeters of mercury. The mechanistic story is clean. Magnesium acts as a natural calcium channel blocker, which relaxes smooth muscle in arterial walls. It also boosts nitric oxide production and reduces oxidative stress in the endothelium. 3 converging mechanisms, all pointing in the same direction. On form, the trial data mostly used magnesium oxide or magnesium citrate, but oxide has notoriously poor absorption. Most clinicians I've read on this prefer magnesium glycinate or citrate for general use, in the 300 to 400 milligrams per day range. Magnesium threonate is the form marketed for cognition, but there's no specific blood pressure trial data on it. The honest caveat is this: if you eat a diet heavy in leafy greens, legumes, nuts, and seeds, you're probably getting enough magnesium from food. The supplement matters most for people whose diet is heavy in refined grains and processed food, because both the diet itself is low in magnesium and the sugar load increases urinary magnesium loss. Check with your doctor before starting any supplement, especially if you have kidney issues. Sleep and stress are harder to quantify cleanly because the trials are smaller and the interventions vary a lot, but the directional evidence is real and the mechanism is well understood. The biggest sleep-related lever is screening for sleep apnea. Untreated obstructive sleep sleep apnea is one of the strongest known causes of resistant hypertension. The repeated oxygen drops during the night trigger huge surges of sympathetic nervous system activity, which keeps daytime blood pressure elevated. CPAP therapy in diagnosed apnea patients drops systolic pressure by an average of about 2.5 millimeters of mercury, and significantly more in severe cases. If you snore loudly, wake up gasping, or feel exhausted despite 8 hours in bed, get tested. On stress, the meta-analyses on meditation and mindfulness-based stress reduction show average systolic drops in the range of 3 to 5 millimeters of mercury. That's a real effect in the same ballpark as cutting sodium. The mechanism is reduced sympathetic tone over time. Most protocols used 30 to 45 minutes of daily practice. Honest verdict, this one ranks lower not because it doesn't work, but because the effort cost is high relative to the effect size. A 2017 meta-analysis in the Lancet Public Health found that reducing alcohol intake produces a dose-dependent drop in blood pressure. For people drinking more than 6 drinks per day, cutting back to under 2 drinks per day dropped systolic pressure by an average of 5.5 millimeters of mercury. For lighter drinkers, the effect was smaller, around 1 to 3 millimeters of mercury. The current World Health Organization position is that there's no safe level of alcohol from a long-term health standpoint. For blood pressure specifically, the trial data suggests that if you're a heavier drinker, this is one of the higher leverage interventions on the list. If you're already drinking lightly, the blood pressure return on cutting further is modest. Okay, here's how to actually run this on yourself. The whole point of a ranked stack is that you can test the interventions and watch the number move in real time. Step 1. Get a validated upper arm cuff monitor. The studies show they're generally more reliable than wrist devices. If a cuff genuinely doesn't fit your arm well, validatebp.org also lists a small number of validated wrist monitors as a backup option. A solid upper arm cuff costs around $50 to $100. Step 2. Establish your baseline. For 7 days, measure twice in the morning and twice in the evening. Sit quietly for 5 minutes first, feet on the floor, arms supported at heart level, no caffeine or exercise in the previous 30 minutes. Drop the first reading of each session and average the second one over the week. That number is your real baseline. Step 3. Pick 1 or 2 interventions from the top of the ranked stack and run them for 30 days. For most people starting from scratch, I pair isometric wall sits 3 times a week with a serious push on potassium and nitrate-rich foods. That's the highest leverage combination with the lowest effort cost. Step 4. Remeasure at day 15 and day 30 using the same protocol. You're looking for a meaningful drop, which in this context means 3 to 5 points or more on the top number. If the number moves, you found something that works in your body. If it doesn't, swap in the next intervention down the list. The whole point is to treat your own physiology as the experiment, with evidenced interventions as the variables. Stay healthy. See you next time.